Hello, my name is Ian McCall, and this is the fourth in the Ken Paver tutorials in dermatology. Now, today we're going to look at linear papules, follicular papules, erythema in papules, and a little bit on pigmented papules. In other words, it's a follow-on from tutorial 3. We're going to ask some questions on Curls disease, Pitt rubra pilaris, urticaria pigmentosa, Fabry's disease, the follicular mucinoses, Dagos, and polyarteritis nodosa. Let's look at follicular papules. Probably one of the commonest you're going to see is keratosis pilaris. Now, this is inherited and is not autosomal dominant. It's in the outer aspects of the arms, sometimes on the cheeks, sometimes on the thighs or buttocks. There's a series of other conditions with different names that are really variants of keratosis pilaris. And some of them, in fact, can give rise to scarring. And one of them goes by the name of erythema oophorogenes. That's where there's significant keratosis pilaris affecting the anterior scalp margin, affecting the eyebrows, and there can be complete loss of them with damage to the follicle by this follicular plug that's there. But the mild type is seen with a roughness with a bit of perifollicular erythema in the outer aspects of the arms and on the thighs. It tends to go after about the age of 35. And as I say, autosomal dominant, often seen in people with atopic dermatitis. And then there's something that looks very similar to it called lichen spinulosus. Now, this particular condition is the spicules are more prominent than in keratosis pilaris, and often in different areas, and they're often grouped. Let's just have a quick look at this particular image of Shabazz januus in Global Skin Atlas. And if we enlarge this, you can see the nature of the follicular papules here. Normally you don't get keratosis pilaris like this around the elbows. It tends to be up in the upper aspects of the thighs. And you can see that these are quite prominent spicules that are here. And if we go back, Shabazz has said that this is a rare idiopathic follicular keratotic dermatosis, occurring mostly in children. I can remember getting a case in my finals in Brisbane when I did it. Young girl with lichen spinulosus. I actually diagnosed it as well. The male to female ratio is 2 to 3. No race predilection, no seasonal variations. First reported by Crocker. I've got a book by Crocker. In 1883, and acute development, symmetrically distributed follicular keratotic papules, sharply grouped, round to oval plaques, varying in size from 2 centimeters to 6 centimeters, the plaques. Extends the surfaces of elbows and knees, other areas, and very rarely lichen spinulosus can be generalized. See, the papule is 1 to 3 millimeters diameter. That's bigger than keratosis pilaris would be. And the skin-colored conical projection, keratotic spine. Might be a better image. Let's look at this one here. Lichen spinulosus. Not going to see it often. I mean, obviously, I think lichen nitidus is one of your differentials, but usually lichen nitidus is smooth-surfaced. It's not that keratotic, rough keratotic surface that you get in lichen spinulosus. Okay, let's flick back. So other follicular papules, lichen planopilaris. Again, you can see, I mean, we typically see this in the scalp area. You can see it elsewhere. There's usually a degree of scale and some degree of follicular plugging that you're going to see in this. PRP, now that certainly gives you a follicular papule. In fact, this is an example of it in this particular image here. And they'll begin as follicular papules like this. Some of them may even show the Koebner effect, and then they join up as these big plaques. So if you look carefully, and it's usually the back of the hands that you're going to see these follicular papules most easily in lichen planopilaris. But Typically we see it as, a generalized red, scaly eruption with some islands of sparing. But if you look, it starts off as follicular keratotic papules, like that. Follicular mucinosis. Okay, it's follicular papule, but it's a prominent patulous follicle opening. And if you squeeze it, you'll usually get some mucin material coming out. Yeah, there's an example. It usually occurs in hair-bearing areas, and sometimes especially the eyebrow. You'll see it in those areas. But, if you would squeeze that plaque, you would get mucin coming out. This accentuation of the follicular openings there. If we could actually get a big enough view to see that. Let's just go back again. Lichen sclerosus epitrophicus. Well, the follicular accentuation there is again plugging, and you know how you get the layer of collagen laid down in the upper dermis, so you get that whitey trophic area, and you may get some little telangiectatic areas where bleeding may occur. And sometimes, if it's occurring in that vulval area where you've got follicular openings, you'll see marked follicular plugging there as well. It's the same with discoid lupus. You'll tend to get follicular plugging. Remember the carpet tack sign as being a prominent feature of discoid lupus. Ken had this, there's a variety of other conditions, but Ken had this sign dip and a mnemonic niggle in IGL, N for nutritional things, where, vitamin A deficiency will give you something like keratosis pilaris with prominent follicular papules. Vitamin C, you can get hair follicles looking a bit more prominent in the lower legs, but you'll get a bit of perifollicular hemorrhage there as well. I'm not sure about essential fatty acid deficiency. Infiltrates, sarcoid, follicular sarcoid will give you follicular papules, and some geniodermatoses, diarrheas, downs, and curls. Curls is usually seen, though, in diabetics. You can get follicular papules there as well. Pityriasis rubra-pilaris, a little bit more about that. We talked about that image there. Red, slightly scaly papules are the fundamental feature, the initial feature of PRP, usually perifollicular. Yeah, this business here, initially they tend to occur on the back of the hands and the neck, so look for those areas if you're looking for these follicular papules of Pityriasis rubra-pilaris. But then they coalesce. Then you've got these islands of sparing. Disease is classified in respect of its onset in childhood or in adulthood, and to whether it's familial or acquired. I think there are about 5 or 6 different types of Pityriasis rubra-pilaris. Worthwhile having a look. We've got a link there to some cases in Derm Atlas. By the way, these other things that we've got here, these other references here, these are to cases as centerfolds in the Archives of Dermatology. It's quite a useful resource, that, of cases, and I used to be able to link directly into it, but you'd need to have access to be able to go, but that gives you the link to go to. Some questions there. We'll come to these perhaps at the end. By the way, if you want to get the answers to these questions, put your response in there and then go down the bottom and click submit, and what will happen is it will then immediately give you the answers to those questions. We can do it this way, or we can have the answers put in underneath the questions. I'll wait and see what the feedback is, and I can change this if this isn't a good way of doing it. Then that second question, which vitamin deficiency will give similar morphological lesions as in PRP? Linear papules. Things can occur in a linear way for these various reasons. Are they basically showing a Koebner effect with scratching and trauma to the skin and the lesions coming up that way? Or is it linear developmental, as a genetic problem that tends to occur in a linear area? Is it linear contact? Remember, plant contact dermatitis typically gives that streaky linear blistering eruption. Or is it linear anatomical because of anatomical features, such as something in the lines of Blaschko, which are embryonic structures, or something along dermatomal lines along peripheral nerves, such as herpes zoster, which is linear anatomical. So, what conditions will give linear papules? Contact dermatitis, maybe. Diarrhea, certainly. Epidermal nevi, that's linear developmental, but linear anatomical. Focal dermal hyperplasia. Now, that's an interesting condition, Gold's syndrome. You get these features here, because this was the case here. You get linear atrophy, telangiectasia, and soft nodules along the lines of Blaschko, because they've got lack of the upper dermis, and so fat comes in underneath the dermoepidermal junction. But they've got these linear telangiectasia and linear atrophic-like lesions along the lines of Blaschko and focal dermal hyperplasia, usually seen only in females because it's lethal in males. I don't know, do we have I think this was a link to DermNet. There's a good little section in here in DermNet in focal dermal hyperplasia and Gold's syndrome, and Amanda has some lovely pictures there. We were talking about, I've got a case as well that I'll throw up and show you, but look at that linear, let's have a look at this. Look at that linear telangiectasia. Okay, see it here? And there'll be little bits of atrophy as well in these, and I think that's a wee girl. But read up about Gold's. It's not a common condition. I had a family in Tasmania that were like that. The mother kept having abortions of them, well, not abortions, well, spontaneous abortions of the male children. Yeah, it's an X-linked dominant. So have a little read up about Gold's syndrome, focal dermal hyperplasia. But it's one of the curious things that will give linear papules, but atrophy with telangiectasia. Herpes zoster, sure, you're going to get linear blisters there rather than papules. Incontinentia pigmenti, another one of those great conditions, again, mainly in females. Males, again, I think it's an excellent dominant. Male fetuses tend to die. Initially, you're going to get your linear blisters that subsequently give hypertrophic lesions. It goes through the various stages. Read up a little bit about incontinentia pigmenti, because they're left with a variety of skin signs that they like bringing out in exams if they happen to have a case. Lichen striatus, usually in younger children, usually on a limb, recent onset, whereas an ILVEN, an inflammatory linear verrucous epidermal nevus, usually been there for a long time, and it does sometimes vary a bit in the degree of inflammation. Slightly different histologies. I think lichen striatus is mainly lichenoid, ILVEN is mainly psoriasiform. Papular mucinosis, yes, sometimes that will occur as linear papules. The acral type. Psoriasis is linear papules only with a Koebner. Sarcoid, certainly warts, yeah. Often you'll see warts will have a linear distribution of mollusca, again, just because of the Koebner effect, and wart virus being impregnated into the skin. So, linear things. Remember the Koebner, linear developmental, linear contact, linear anatomical for the reason. And this was the photo of an inflamed linear verrucous epidermal nevus. And you can almost see the sort of psoriasiform look, red scaly look to the surface of this. Pigmented papules. Trying to think. I think they're more difficult. I think indicated before that usually it's more difficult to make a diagnosis with pigmented papules. I think this condition is the one you'd need to think about most, urticaria pigmentosa. Now, in children, it tends to be a more macular rather than a papular eruption. But of course, they urticate when you rub them, diarrhea sign. Xeroderma pigmentosum, that's the rare genetic disorder of DNA repair mechanisms. I think there's about 7 variants or something. And they get severe sun damage in young children. Marked freckling, first of all, then solar keratosis, then skin cancers and melanoma as well, but it's all in sun-exposed areas. Fibrous papule of the nose. I don't know that that's usually pigmented. It's usually skin-coloured, in my experience. And you can get them in the tongue, get them in the lip. Gottron's papules in the back of the hand, over the MP joints in dermatomyositis. They're purplish. Much that is the same sort of hue as you get around violaceous hue around the face in dermatomyositis. Lichen planus, sure, again violaceous, but usually the papules are going to be in the anterior wrist. You know, they're in the anterior aspect of the hand or the wrist, and violaceous, and they sometimes join up as plaques. Forget melanoma, lymphoma, leukemias, sweets. No, they're usually nodules, most of those things, rather than papules. Same with MF. Kaposi's, though, that could present as purplish papules, and you might misdiagnose it. This was, I think, a DermNet reference on mastocytosis, worth having a look there. And this was some dermatologist cases as well. I won't bother going into these just now, but you can look at these when you're going through it yourself. What have we said a bit here? Urticaria pigmentosa, proliferation of mast cells giving hyperpigmented macules. Yeah, I thought they were mainly macules. Urticate on pressure or rubbing. Other accumulations of mast cells give macules, papules, nodules. Solitary mastocytoma, that can present as a plaque in a child and may only blister when it's rubbed after a bath. But remember, you can get vesicles abulae as well in urticaria pigmentosa. And then there's this adult variant, TMEP, telangiectasia macularis eruptiva perstans. The TMEP variant gives us telangiectatic hyperpigmented variant of mastocytosis. Occasionally there will be virtually no skin lesions, though biopsies may show high numbers of mast cells. Difficult to do a biopsy for mast cells. I think they want 6 or more, I forget the area, maybe it's in a square millimeter, to say an increased number of mast cells. But you've got to watch, if you stick some local anesthetic and do a biopsy in that area where you put the local, it often degranulates the mast cells and they can't see the mast cells. So you've got to sometimes do a sort of ring block elsewhere, a ring of local, and then in the middle of that area, go in there for your biopsy. And they need to ask for this, they need special stains as well. What have we said about urticaria pigmentosa? Cases that come on in childhood are likely to spontaneously involute. Yeah, most of them do. Generally by the age of 10, the orangey brown lesions of urticaria pigmentosa will involute and disappear. This I've said here was a photograph of urticaria pigmentosa. They look macular. Some of them may seem slightly papular, and they will become papular if you rub them. They'll urticate. But you just got to think about it with these browny papules of urticaria pigmentosa. And there were some questions there. You can look at these yourselves afterwards. What about erythema and papules? Here was some information that Ken gave us to think about. If you've got virtually all erythema with just a few papules, and it's a child with high fever, it may be scarlet fever. Have a look at their tongue, see if they've got that strawberry tongue, the white and then the pink strawberry tongue, depending on whether there's an exudate on it, and then when it comes off, you get the strawberry tongue. Feel the skin. It often has that rough sandpaper sort of feel to it as well in scarlet fever. We don't see it as much nowadays. Remember, later on, after their ash is gone, they may get some peeling of their fingers on their toes, where you get that post-streptococcal peeling of the skin. So they may bring them into you at that stage, and you can tell that they've had at least a strep infection beforehand, may not be scarlet fever. Big problem this in Aboriginal communities, often brought on because they've got scabetic lesions from their dogs, and they get the scarlet fever from that. They get it into the skin anyway from that. What about all erythema plus a few short-lived little papules? Where the erythema comes, little papules, itchy, goes within half an hour, usually comes on after exercise. That's cholinergic urticaria. I think these are references to DermNet that you can fix up. Erythema and chronic papules, PRP. So remember, look on the neck, look at the back of the hands to see if you can see the follicular papules, but it's generalized erythema with islands of staining. Chronic papules with no erythema. Well, don't know why that's up there. Lichen myxedema, particularly in the arms. Remember, lichen amyloidosis is particularly in the legs. Erythema with non-infiltrating papules. That's Sézary syndrome. That's a T-cell lymphoma of the skin. It's the erythrodermic phase of a T-cell lymphoma, diagnosed by having 1,000 or more Sézary cells in the blood. It's a leukemic form of a T-cell lymphoma. Succinate papules. Ken had this mnemonic, signed it LEP, L-E-P-P. Lichen sclerosis erythrophicus, elastosis perforans serpiginosa, giving a sort of annular or succinate type pattern. Some pustular disorders will give succinate, almost give succinate patterns. Pemphigus and porokeratosis can sometimes give succinate patterns as well. Let me just flick into this one on elastosis perforans serpiginosa, because again it's in DermNet and there should be some nice images. Well, that's one there. Remember, this is a disorder of elastic tissue, thick fibers of elastic tissue that are expelled through the surface of the skin, and this condition can be associated with a variety of other disorders. So if you see elastosis perforans serpiginosa, go looking for other conditions that they may have. And here are these inherited disorders here. Down syndrome, again with these keratotic papules, Ehlers-Danlos syndrome, Marfan syndrome. Well, this, I actually thought EPS was a feature of that other disorder that has brittle bones and gives you blue sclerae. A quick mental block on what it was. But I thought it was a feature with that as well. So have a look in here at DermNet on that particular condition. But succinate papules, elastosis perforans serpiginosa, and pustules we've said would include necrolytic migratory erythema. That's the glucogonoma syndrome. They get advancing pustules at the edge of an area coming out from the flexures, particularly the buttocks and the like. And it may have a picture that's very similar to this, acrodermatitis enteropathica, zinc deficiency. Except that's usually seen in little kids, premature babies, or mothers who've got milk that's deficient in zinc, and the little kids get the acrodermatitis enteropathica. A spreading buttock rash and a rash around the mouth as well, sometimes with little pustules at the edges. Subcorneal pustular dermatosis, that's an IgA dermatosis. Often a hanging pustule, in other words, a blister with a little hypopine, that there's a little level of pus in the blister itself. And impetigo is similar. Why did we put Fabry's disease in there? Angiokeratoma corporis diffusum, I suppose because they've got a lot of pink or purple-like papules, particularly seen on the buttocks, but also in other areas, because Fabry's is a disorder typically seen in males. I think this is these are just the ordinary angiokeratomas of Fordyce, an aging one that you get on the scrotum. But in Fabry's, skin lesions are small punctate, vascular papules, slight hyperkeratotic tops, usually in the lower legs and around the scrotum and penis, and they may curiously congregate in the midline of the lower lip. Patients also present, this was something Ken used to emphasize, with a curious burning sensation of the hands and feet and reduced sweating. And the burning sensation in the hands and feet is reduced by elevating the arms. It's a disorder of lipid deposition in the skin and in nerves. I've only seen one case, and I remember it being demonstrated at a meeting in Sydney once. So not common Fabry's, but worth looking at. I think we have renal problems in Fabry's as well. Kuhrel's disease, we've spoken about this before. It's one of the perforating disorders, and it's a papular disorder of the lower legs. A horny cone projects into the dermis itself, or from the dermis out into the epidermis. I suppose it's projecting in the way, and when you remove it, there's a pit that extends deeply into the skin, and the lesions may coalesce to form a plaque. Usually it's associated with diabetes mellitus, often with accompanying renal failure. And I think we had, let me just flick into Global Skin Atlas, because I'm sure we had a good case here that I may have shown you before of Kuhrel's disease. Let me just get to it. Kuhrel's. At least I thought we had. There we go, this one. This was one of mine. Young lady, these were the lesions on her thigh and buttock. You can see the keratotic plug in the middle of some of these lesions. If you try and pick that out, it leaves that deep pit. So they are keratotic papules that they get. Okay, so Kuhrel's disease, and think of it also in relation to reactive perforating collagenosis. We sometimes apply that term to a different age group, younger people getting this without the associated problems of diabetes and renal failure. What was this one here? Oh, this was just the papules of reactive perforating collagenosis. Looks a little bit like prurigo nodularis to some extent, some of these, but perhaps not as big as you would get with those. But again, just a little keratotic papule that you see. Malignant atrophic papulosis, Dago's disease. This is an interesting one. This is what you look for, this porcelain white central area with a bit of surrounding erythema. This is an area of vascular necrosis in the skin, and the problem is these lesions can occur in reasonably big blood vessels and occur internally, often in the gut and kidneys and even in the heart. And so these patients can suddenly die, or they may get bleeding in the gut, and they may get Mark Malina and problems. But this is what the lesion looks like. I mean, I've seen some patients with severe vasculitis who have healed and left white scars like this. But these ones can often appear without an awful lot in the way of preceding erythema. So it's a curious condition, Dago's syndrome. Papular disorder, center of the lesion is a pale white scar. Lesions may be umbilicated with a central depression. Yeah, the center of the lesion is also described as being porcelain white, while the periphery becomes red and telangiectatic. Well, that was a nice example of it down there. Atrophy occurs eventually. The condition crops. As well as affecting the skin, the condition also affects the intestines, giving rise to abdominal bleeding and perforations. Cerebral infarction can also occur. It's a necrotizing vasculitis, and inherited forms have been reported. Worth having a look. It's worth just having your eye in on that particular image with that porcelain white center there. Some people sort of felt that it was a variant of lupus, but I was never. I just haven't seen enough cases to have any opinion on that. I remember John Doyle, the late John Doyle. John, I think, felt that this was always a variant of lupus, in fact. By the way, there is a site. That particular image came from this particular site. There's a dagosdisease.com, and there's a series of images in there. Some patients have put in their images, so it's worth going in and having a look at these different images from patients with this condition, because it's so rare you're just not going to see it much at all. Polyarteritis nodosa. Okay, does this give papules? Papules are nodules, and usually on the lower legs, subcutaneous nodules along the course of blood vessels. And remember, there's two variants. There's the relatively benign cutaneous variant, where it's only on the lower legs that these papules occur, and there isn't any involvement of vessels elsewhere. And then the systemic variant, where there are significant involvement of vessels. And if significant vessels are involved, then you'll get areas of skin necrosis like this. Now, often polyarteritis nodosa can be associated with livedo reticularis. They have livedo of the lower legs. So if you see livedo of the lower legs, if you feel some little subcutaneous nodules there, then you've possibly got polyarteritis nodosa. Got to watch for kidney damage in the systemic form. If you're doing a biopsy on these nodules, it's not a punch. Remember, these vessels are going to be fairly deep. You've got to do an incisional or excisional biopsy of one of these nodules to be deep enough. You know, get right down to the fat. You're going to be deep enough to show where these vessels are. So, in polyarteritis nodosa may occur singly or in groups. Skin, yeah, may show evidence of livedo. The nodules are often painful. I think that's useful. Two major forms are described, benign cutaneous form and systemic form. Polyarteritis nodosa of latent diagnosis will present with cutaneous ulceration and infarcts. You know, pulp infarcts in the fingers are also common. Remember we did a little thing on pulp infarcts, or at least small infarcts, scleroderma, Raynaud's, subacute bacterial endocarditis. I think lupus and the like had to be considered mixed connective tissue disease as well. And cutaneous PA, as the name implies, there's no systemic involvement. There's some cases here as well that you might want to look at. Follicular mucinosis. Worth seeing, you know, there's appears to be a benign and a malignant variant, and the malignant variant is one of the variants of T-cell lymphoma. It may present as a follicular mucinosis. It may present often as one or more plaques, particularly on the face and neck. The plaques are generally skin-colored because they may, but may be red or even hypopigmented with a slight eczematous look. Yeah, pressure on the plaque may exude mucinous material from the hair follicle opening, and the hairs themselves can be damaged. You can get a broken off at the skin surface. Yeah, the surface sensation may be diminished in follicular mucinosis to light touch mimicking leprosy. Childhood presentation, usually on the head and neck, generally a solitary plaque, and spontaneous resolve in up to 2 years. Usually it involves an eyebrow, at least in my experience it involves an eyebrow. But multiple lesions in an older patient can be a manifestation of T-cell lymphoma. Mucin within the cells of the sebaceous gland in the outer root sheath. And in those associated with MF, the cellular infiltrate, the lymphocytic infiltrate, is atypical. This was a young lady we had who had lost the outer third of her eyebrow, outer half of her eyebrow here. You can see the plaque of follicular mucinosis here. And if we enlarge that image, I apologize, it's not big enough. If you look around the follicles, you would see mucin deposited along the outer edge of the hair follicle here. And as I say, sometimes there's damage to the follicle. And the other name used to be alopecia mucinosa. And then there's one here, I think, in the archives, you know, asymptomatic follicular papules with alopecia in the lower part of the leg. Well, that'll be alopecia mucinosa. I think this is the DermNet reference here. If you want to go and have a look at it, you can see that there's that variant that they were talking about in the legs there, with loss of the hair, a bald area in the lower part of the legs there, where it's not alopecia areata, it's follicular mucinosis. Some other examples here. There's a plaque here on the face. So worthwhile going in and having a look at these, and just having a little read here about the various types of alopecia mucinosa that you may in fact see. It's an important topic that we'll see these sort of cases. They'll bring these sort of cases to exams if they've got any out there. And we ended up with a series of questions. To get the answers to these, just put your responses in this section here and click submit, and you'll get them. You know, what conditions may be seen in association with EPS. That was some of the genetic disorders we talked about. Skin lesions are seen in virtually all cases of Gold syndrome, focal dermal hyperplasia. What are they? Remember, it's part of the linear developmental there with the telangiectasia and the patulous soft nodules. because of the lack of dermis there. What histological test may help in differentiating linear lichen planus from the other linear disorders? Histological test. I think it's immunofluorescence. It might help you as far as that goes. What are the clinical variants of porokeratosis? There's all sorts of clinical variants of this. You know, there are linear variants and succinate ones and disseminated superficial and solitary porokeratosis of my belly, etc. And there, yeah, just try and think again. How does lichen spinulosus differ from keratosis pilaris? Think of the size of the spikes. Think of the distribution of them as well. Okay, that's tutorial 4. I hope you enjoyed it. Thank you.